Thank you, ma'am, and thank the organizers for giving me this talk. Well, the topic of this whole session is listen to the inner voice. But when we look at this topic in particular, which is the status of training and satisfaction level of future pediatric cardiac surgeons in India, is no longer an inner voice. It is a cacophony around us. We all know for many years now, surgeons have not been good quality pediatric cardiac surgeons have not been coming in for training. People who have been coming in for training are trying to practice both pediatric and adult. So let's quickly have a look at what is happening here. Why are we going through this crisis in our specialty? I have no disclosures apart from the fact that I may be falling in between the senior surgeons and the junior residents, and that's why I've been given this talk. So the issues I will dwell on is what is the burden of congenital heart diseases in India. Well, this part has been dealt with many a times over the past few days, so I'll quickly go through it. Let's define what training is and what satisfaction is. What's the present training pattern in India and how does it compare to the rest of the world? Are we doing it right? Do we need to change? So starting with the burden of congenital heart disease in India, I'll again refer back to a paper which was shown a couple of days back from Dr. Anita Saxena, which was published in 2018 in Indian Pediatrics, which says 240,000 newborns annually with congenital heart disease in our country, of which 50,000 require intervention in infancy. And all in all, there are almost 2 to 4 million patients with congenital heart disease at present in all age groups. And in this massive number, this just 1 in 8 children get treatment for congenital heart disease. There's a wide regional variability. High quality congenital healthcare is limited to tier 1 cities and now probably trickling down to tier 2 cities. And it's a massive task for the healthcare workers, especially us, to deliver quality care to all our patients. This data was brought up by my friend Ashish a couple of days back when he was discussing where we'll reach in 10 years from now. He says that this year, 223,000 kids were born with congenital heart disease. There are only about 100 pure pediatric cardiac surgeons in the country. 40,000 surgeries are being conducted annually. 100,000 surgeries should be conducted annually in our country. There should be 500 centers. There should be 1,000 pediatric cardiac surgeons, and that's a minimum. And I refer to this paper by Dr. Krishna Kumar, which came out 5 years back, when this whole sickness of congenital heart surgeons not coming in for training started worldwide, says that if there's a high requirement and there's a low supply, why is the supply chain drying out? This is contrary to the basic laws of supply demand. And why is this happening? So let's have a look at why is this happening. Before getting into that, let's define training and where we are failing, where we are succeeding. So training, as per the definition, is a process of learning the skills you need to do a job, which is synonymous with drill, exercise, practice, so much so that it becomes a workout and a routine for you. So a congenital heart surgeon has to operate successfully on a variety of complex congenital heart lesions in all age groups, produce results of international standards, most of the time double up as an intensivist, handle the financials because the hospital wants you to make a profit, be a leader of the team, if at all he or she has any. The reality check also came from America, and this paper from Charles Fraser was published in 2015 in JTCVS. It's an editorial from there. And that's the time when the American system, who are supposedly the best training system in the world in the medical field, had converted to ACGME accredited congenital heart fellowships and training programs. They have 12 centers in the country. There were 44 trainees that year. And of the 44 trainees, a questionnaire was sent out and 25% of trainees didn't reply back, which they thought that was a cause for major concern, because these people did not want to come out with what was going on. Also, only 22, that's 50% of the trainees had completed a congenital heart fellowship. And what is most worrying for them was that the median age for these trainees was 40 years. 40 years. The individual has passed half his life, and still, if you go into the last two lines, still not comfortable with doing complex neonates, hasn't had any exposure to the non-surgical part of congenital heart disease management, which is echocardiography and catheterization. What happens in India? So this is one extreme, the richest country in the world, which boasts of the best training programs and the best centers in the world. All congenital heart surgery training in India is primarily informal. A few years back, the Indian Association tried to establish training posts which were more formal. The 3 high-volume centers in the country of excellence were selected. Trainees coming and joining these programs have been sporadic. As of now, there's only one resident who is in training, rest there are no takers. Unfortunately, there's no structured training program. Training is more didactic, it's not hands-on. Independent or monitored handling of operations in our system for trainees is actually a rarity. The big problems which we face as moderately senior or very senior cardiac surgeons, and as a fact that we have to look after our specialty, and which Dr. Krishna Kumar brought out in his paper. What are the training opportunities and which institutions train congenital heart surgeons? None of the government institutions do. There are no organized training programs in any academic centers. A trainee who finishes his MCH or a 6-year DNB has hardly any exposure to congenital heart disease, or a minimal exposure, which in no way makes him competent to handle even the basic stuff. The training environment in private setups or in other hospitals where these post-MCH fellows go for training is very isolated, in the sense that there are hardly any training programs running, where the environment is a more comprehensive environment requiring radiology to come in and pediatric cardiology to come in. Mentorship, which is the most important part of growth in this specialty, is by and large missing in our country. Being a good surgeon is not being a good mentor. One might be an average surgeon, but a very good mentor. One might be an excellent surgeon and not a good mentor. Working conditions are stressful. Trainees have to do ICU duties. They have to learn intensive care. They have to blow their brains up with the inotrope requirement and the ventilatory settings, which actually shouldn't be their job. And after all this and years of training, when they come out trying to look to establish a successful career, which in itself is a challenge. So I wanted to do a survey and I sent out 50 questionnaires. I got 3 replies. This is a bigger problem than what the Charles Fraser and his party faced. Rest, I had telephonic and casual conversations with 13 people who could be approached. So out of 50 people, 16 wanted to come out with what problems they were facing. Do we have a problem? Yes, we do. All these people were within 1 to 5 years post MCH or DNB. They were training at various centers in the country. They were all males. One person was below 30 years. 15 people were 30 to 35 years, and one person was touching 40. And at this stage, none of these people were competent to look after any congenital heart disease. 90% of the respondents felt that they would do combined adult and pediatric practice at some stage. They all wanted to train abroad, most important point being enjoy a few years of work-life balance. Their concern for training in India was low hands-on experience, and 90% felt that it would take them another 4 to 5 years to become fully competent. All respondents and understood the challenges of a pediatric program. We have heard these earlier. And when I defined satisfaction to them, I got a very good reply. A surgeon who wants to be a pediatric cardiac surgeon cannot expect to define job satisfaction based on earnings alone. Money is an important factor, but to work successfully with a team gives you much better job satisfaction. So their suggestions, all the 16 combined, was better hands-on experience, more simulated training modules, develop pediatric programs which are more comprehensive, develop a better perfusion team, train the nursing staff, but most importantly, better pay and incentives to all these groups to attract and not deter them. Now, the training sequence in the real world, this Tom Carl's paper from about 4 years back, which he was very kind to share this slide with me. Then an average worldwide time to reach to the first arterial switch operation is between 30 to 52 years and a median of 36.5 years. I can assure you none of our trainees in India have done an arterial switch at 36.5 years. So what is really important is we need to reach a training program that emphasizes on content and competence, increase the time in pediatric areas. Pediatric cardiology and cardiac surgery should be treated as a singular specialty. We have to adopt newer teaching methods, realistic guidelines for experience, international board certification. I'll just take 30 seconds more. Maintenance of expertise of both mentors and mentees, and continuation of mentorship over a lifetime. So these are the points which we discussed. Again, I will not dwell on these because these points have already been taken care of by Dr. Paul and Dr. Iyer. Now I'll give a closing salvo. Dr. Rajesh Sharma published a paper on becoming a pediatric cardiac surgeon in India. And Pranav Sinha, who is a consultant in Washington now, was a fellow at that time. And he had written a letter to editor after permission from Dr. Sharma. That knowing this, providing a resident, multiple studies have shown that no significant difference in results in patient undergoing cardiac surgery between residents operating under supervision and staff surgeons happen. Knowing this, providing a resident with ample operative exposure is the least a trainer can do to fulfill his responsibility. Pediatric cardiac surgery separates the men from the boys. That's what Christian Bernard said. But who is going to take these boys through their puberty? It's our responsibility. Gentlemen, please listen to the voices around us. It's no longer an inner thought. Thank you very much for your hearing.